So thank you very much for joining us today for looking at AI in general practice and cutting through the noise. So this is a session brought to you by Redmore Health and the Digital and Transformation Network. And we're also joined today by Ethos, who's a governance and compliance company. They're doing it jointly with us today, and you'll meet Stuart a little bit later. So just to start with a little bit of housekeeping, so please be aware that your videos and microphones have been turned off while we go through the presentation. And if you've got any questions during the session, please pop them into the Q&A section on the top banner. Others will be able to upvote any questions that they would like answered as well. We're going to go through how to do that on the next slide if you're not sure about that. Please be aware that we will be recording the session today and it will be available to view afterwards through the D&T Network. And then again, if you haven't registered for the session directly through us today, if you joined via a link that was shared by somebody else, please do make sure that we have your email address and job title in the chat so that we can invite you to the D&T network if you're not already a member, because that's where all the free resources will be after today. And lastly, I'd just like to ask a question first so we can get an idea of who we have with us today. So the first question, or the only question at the beginning, is do you currently use AI in your practice or PCN? So Kirsten, are you able to launch that poll?
Yeah, just give me 1 second.
Thank you. Fab, thank you very much. Just so we've got an idea of whether you currently use it, whether you don't use it at all, or whether you're not sure whether you've got it or not. So give us a bit of a good idea of who we've got. So we've got about 60% of people that have already got AI, about 6% that aren't sure. So we can look into that. Fabulous. Okay, so this is how you can use the Q&A panel. So if you'd like to add a question in for the panel that we've got later in the session for the Q&A, use the Q&A function on the top banner of Teams, and this will help us keep tabs on all of the questions as we're going through. You can upvote the questions. As you can see there, it's the arrow if you'd like that question answered as well. And what we'll do is we'll select the most voted questions to be answered live today. And as always, if we don't manage to get to all the questions today, we'll endeavour to get them answered for you and share them afterwards after the session. So this is the plan for today's session. We're going to be looking at why we're talking about AI, what it can and cannot do currently, patient engagement, so looking at the way that we engage with patients and tell them about AI. We're going to look at some next steps that you can do. And then Stuart from Ethos is going to dive into the governance and risk side of things. And then we will be telling you what help is available from us. And then we'll be coming to a live Q&A section. So AI, we know, is rapidly entering the world of general practice, and hopefully this session will cut through the confusion, highlighting some practical examples of AI that's already being used in primary care, and we can share what practices and PCNs need to consider before implementation, including how to engage positively with patients. So we'll run through some essential tips and tools for information governance, outline key steps like DPIAs and supplier due diligence, and provide access to resources to support safe and scalable adoption. So why are we talking about AI today? So there is no doubt that AI is a hot topic in general practice right now. So it's being talked about in nearly every forum. It's in the news, it's at national events, in ICB meetings, across digital communities. But alongside all that interest, it's also growing a sense of confusion. So with many tools, pilots and acronyms being thrown around, it's not always easy to work out what's relevant, what's useful and what's just noise at the moment. We often hear the question, is this hype or is it actually helpful? And the truth is, perception varies widely, but some people are excited by the possibilities while others are understandably a bit skeptical. And that's especially true when you look at the gaps between what's being promoted at an ICB level versus what's being delivered or experienced on the ground in practices and PCNs. But there are very real opportunities here. If we cut through the noise and focus on what's already working, AI can free up time. It can reduce admin burden and support better patient care. We're already seeing this with tools that summarize documents, support coding, or assist in triage workflows. There's also a clear national direction of travel. So NHS England and ICBs are increasingly pushing forward with digital strategies that include AI, and several pilot platforms are underway. If practices understand this momentum and what's coming next, they can make more informed choices now and avoid being caught off guard later. At the same time, we can't ignore the fact that patient expectations are changing too. So, as AI becomes more common in everyday life, think about chatbots and virtual assistants, or even just on smart devices. Patients will naturally begin to expect those same smart, seamless experiences from their healthcare providers, and we need to be ready to respond to that shift. AI is coming, whether we feel ready or not. That's why it's so important to approach this with clarity. By focusing on governance, safety, and scalability from the start, we can adopt AI tools in ways that genuinely support general practice rather than overwhelm it. And in this part of the session, we're focusing on cutting through the speculation and being really clear about what AI can already do in general practice and what it still can't. So let's start with what's working. So there are some very real and practical use cases already in action. Practices are using AI tools for admin triage, automatically categorizing patient requests as clinical, admin, or urgent. And there are tools providing coding support, which can read incoming documents and suggests NOMED codes for clinicians to review. We're also seeing the use of AI for demand and capacity analysis, helping practices plan their workforce and appointment types more effectively. And these are real applications, not just pilots, and they're happening right now. There's also a new and exciting way of communicating with patients through systems like Synthesia. So, by using AI generated avatars based on real team members, we can produce informative content on a range of health topics that can be shared on social media, websites, or waiting room screens to help patients access clear and trusted information. And this on here is a screenshot of what it looks like. But if you'd like to see a demo, get in touch and we'll walk you through what's possible. But it's equally important to acknowledge what AI is not yet capable of. We're still a long way from tools that can safely and independently diagnose patients or replace clinical judgment of GPs. That's not what these technologies are designed for, and we should be clear not to overstate the capabilities or let suppliers do that either. There's also some confusion around the term AI. When people hear AI, they often think of ChatGPT or other generative models. But most of the tools being used in primary care are not about generating content. They're designed to support operations, processing forms, summarizing documents, or flagging workload, not writing poetry or having conversations. It's a very different type of AI with different risks and benefits. And one of the most common pushbacks we hear from practices is we don't have time to look at this. But that leads to a bit of a paradox because the whole point of using AI is to save time. So if we never make space to explore these tools, we risk staying stuck in that time poor cycle. To put this in perspective, we can look back at previous transformations like the introduction of telephone triage or electronic prescription service. Both were met with skepticism at first, but they've since become vital parts of how general practice works today. AI may follow a similar path, initial resistance followed by real operational value. And I'll pass over to Sarah now, who's going to talk through patient engagement.
Hi everyone. So we're going to look at patient engagement a little bit. So when introducing AI tools into general practice, engaging patients isn't just a courtesy, it's essential. So it's essential for building trust, supporting safe use and driving adoption. So first, involving patients in co-design helps ensure that new systems actually meet their needs. So collaborating with a diverse group of patients using surveys or forums and closing the loop by feeding back how their input has shaped decisions all help build confidence and relevance. Secondly, communication is key to addressing concerns around privacy and ethics. Patients need to know that their data is secure, that AI isn't replacing clinical judgment, and that a human, a clinician, is always overseeing decisions. Making this explicit reduces fear and misinformation. So patient engagement supports transparency. By linking to privacy policies and clearly explaining how approved tools are being used, we can reassure patients and encourage more meaningful participation into their care. So being transparent about how AI is used in care, it builds trust and it helps patients feel more in control. This is especially important when tools like ambient scribes or automated systems are involved. These can feel invisible, but still really do impact the patient experience. So start by clearly explaining where and how AI is being used. This could include summarising letters, flagging information, or supporting appointment triage. Patients need to understand that AI is there to assist them and not replace clinicians. Language is really important too, it really does matter. So terms like digital process or computer assistant can feel less intimidating than AI systems. Avoid technical jargon and use plain language wherever possible. Importantly, gain informed consent where appropriate. Some tools, such as ambient scribes that capture conversations to produce documentation, should always be disclosed up front. So let patients know what's being used, why, and how the data is handled. We also have to consider digital inclusion, so not every patient is online, and it's vital that we offer this information in multiple formats, such as posters, translated leaflets, or simple verbal explanations. AI engagement should be inclusive and equitable for all. So being open about the use of AI is not just good practice, it's how we maintain trust, improve understanding, and ensure safe adoption. So when it comes to communicating about AI, not all patients need or even want the same depth of information. That's why it's important to offer different levels of detail through a range of channels. So from brief reassuring messages to more in-depth explanations. Start by educating and empowering patients. This might be through short educational sessions, such as how AI helps your GP and how you're still in charge. These sessions help demystify AI and reinforce the human oversight that patients often worry about. You can also share simple explainer videos on your website or social media. These should cover what AI is doing and what its involvement is in healthcare, whether it will affect face-to-face care and how patient data is protected. Tools like Synthesia make this easy to do in a clear, accessible format. So next, think about social media. Think about it as a positive tool. Share updates using warm, reassuring language and highlight real stories of how digital tools help both patients and staff. This helps build a narrative of partnership and progress. Don't forget to reference co-design. Show that patients are part of the journey and not just recipients of change. And of course, keep your website up to date. It should include layered information from short summaries to detailed FAQs to suit different preferences. Make sure you address common concerns like, will I still see my doctor? Does AI read my private information? That reassurance really does matter. By using multiple formats and platforms, you can reach more people, support different learning styles, and help patients feel confident and informed. So here at Redmore Health, we have a social media managed service, which can also include the AI avatar video content service. This is able to support you to get more reach and engagement from your patients. So if you're interested, please just contact us or pop a note in the chat and we'll give you a call. So when you're introducing AI into general practice, it's essential that communication reinforces trust, transparency, and a human-centered approach. So the 3 key strategies to support this. First, reinforce the human side of care. Patients need to know that AI is a supportive tool and not a replacement for their doctor. Use phrases like AI is our assistant, not your doctor, or it helps us work with you, not instead of you. These messages reassure patients that their care remains personal. Explain the benefits to them. It saves admin time so we can spend more time on your care. It makes them feel more relatable to use images of real patients and staff, not just technical or robotic visuals. Secondly, normalise AI use within the practice environment. So use waiting room screens and digital touch points to share friendly, reassuring messages, such as some of our GPs use AI tools to help review your notes. This means more time focused on you. It's also helpful to include consent prompts. So when AI tools are used for specific functions like messages or symptom checks, this builds understanding and reinforces the informed consent element. Finally, add a personal touch to AI-generated communications. So whenever an AI-assisted message is sent to a patient, make sure it's signed off with a name or a friendly tone, something like sent by your GP team with a little help from our digital assistant. This blends efficiency with empathy and it ensures the technology doesn't erode the human connection. These small communication choices can make a big difference in how patients perceive and accept AI in their care journey. So now that we've explored how AI is entered into general practice, and before we hand over to Ethos, here's some practical steps you can take right away to move forward with confidence. So 1, review what you're already using. Start by mapping any tools or processes in your practice that already include elements of AI. This might be coding assistants, triage forms, letter summarization tools, or even chatbot functions. Knowing what you already have is the first step to understanding risks, opportunities, and where to improve or expand. 2, ask your ICB, what's our AI policy? ICBs will be developing or refining their stance on AI, especially in light of the evolving guidance on data security, digital maturity, and clinical safety. Understanding their position helps ensure any decisions that you make are aligned with system-wide governance, including DPIAs and safety case requirements. 3, join pilot programs and share learning. Get involved with early adopters, whether through NHS pilots, supplier initiatives, or local innovation schemes. Participating gives you a head start. Equally important is feeding back your insights. So share what works and what doesn't within your practice, other practices, and your PCM, and networks like ours and the AI Ambassador Network. This accelerates safe adoption across the system. 4, use resources from the D&T Network. So the D&T Network offers tools, webinars, templates, and peer support. So whether you're looking for a patient messaging template or a case study of AI used in real practice, it's a great place to start, especially if you're unsure what's safe or feasible. Then take up the offer of the joint support with Redmore and Ethos. We can help you to get started with implementing AI solutions into practice and to feel confident that your patients are receiving better care as a result of that. Stay with us for the full details that will be later on in the presentation. And then 6, getting started with AI toolkit. A guide from Redmore and Ethos for getting started with AI is available in the D&T Hub. If you don't have access, please let us know and we'll contact you to talk through how you can get it. So at the minute, there's a lot of NHS guidance around AI, and some more recent information has been given regarding ambient voice technologies. Links to this information will be in the resources of the D&T network that I've just talked about. So now I'd like to hand over to Stuart from Ethos, who for almost 2 decades has been working alongside digital health leaders on their journey to navigate safe security and regulatory fields. Stuart?
Hello everybody. Thanks for having me. So there's a lot to take in there, and I'm hoping that my bit won't send you all to sleep. What I'm looking to do is give you a bit of background on some of the technologies, so a bit of a more detailed background, and also some examples. And what I tend to do with my content is just let me get to the right slide. Here we go. Is give some examples, the reference with some articles. A copy of this presentation, I'll have it linked embedded. So when we talk about ambient scribing, I'm hoping to provide just a very simple definition and overview for those that are perhaps a little bit more interested and a little bit more technically astute. However, that isn't a requirement in this space. It's just trying to find a common level amongst the 136 people that are on here. So ambient scribing, it leverages natural language processing, automatic speech recognition, which has been around for probably over a decade. And they usually work on a ChatGPT type model, and they're trained specifically using medical terminology and also consultation patterns. The technology in process employs a process using audio and contextual data. It uses a speaker diarization, and that distinguishes between the clinician and the patient from a voice perspective. And it then goes through a recognition process to extract all of the relevant information, like symptoms, medications, and diagnoses. So there are a few modern systems out there that are linked with HIPAA and GDPR compliant processing models, and they're all encrypted, but they're few and far between, which is probably why the NHS guidance has come out, or two in successive. They've obviously detected a little bit of an issue that they want to surface and focus on the manufacturers and unfortunately you guys as well. What we can see with some of these ambient scribing technologies are claims around up to a 50% reduction in documentation time. So there's massive time savings and removing some of the need for manual typing and clicking through screens of the medical record. We can see some of these solutions provide structured notes and coding and even suggest codes based on the consultation content. So they're quite powerful. The ambient scribing tools are quite powerful. And that's just one of the three areas that we're defining in the context of this presentation and the panel discussion later. RPA, robotic process automation. Again, that's been around for a while, but now new technologies are enabling these systems to mimic human actions and run in a consistent or supposedly consistent and 24/7 operation. Some of the more modern systems now can use optical character recognition, so they can read screens, process documents, and the interface with other systems or applications. And we can see from some of the work that we do with our clients is that RPA bots can extract data from registration forms using some form of intelligent document processing, validate the information against the different databases, and then trigger other processes such as appointment scheduling. Now, some of the systems can do a little bit more stuff in terms of recognizing when a patient might have a duplicate episode or duplicate record based on base criteria such as a name, spelling of the name, address, and other contents. So it can be helpful. And the architecture tends to be centrally hosted in terms of the GP practice, or the ICB have commissioned these solutions tend to be centrally hosted. So that provides some comfort around the security and the access of your data. So enhanced communication tools. This is a little bit more of a deeper dive here. It employs models that are tuned on medical communications. They understand the medical context and can distinguish sometimes between routine follow-ups and urgent clinical matters or clinical concerns. So, and these tend to be a little bit more of a clinical decision support in nature, and they can cross-reference to current medications, test results and care plans, and provide context-specific suggestions. So before I move to the next slide, these workflow improvements are just the beginning. They proliferate in the market quite considerably. The volumes there It's quite intense. So let's have a look at how AI is advancing the care itself. So moving beyond workflow optimization, AI is making quite a significant inroad into clinical decision support and clinical decision making, patient monitoring, and more. And there's a real-time activity around patient monitoring to hopefully improve patient outcomes. So there's not there's a massive upside, but there are obviously issues if not handled correctly, and we'll move on to that later. So from a diagnostic support tool perspective, we have documented evidence around accuracy and sensitivity rates above 95%, particularly for things like diabetic retinopathy, some screening services, and other things like that. These technologies use customized models for things like image-based data, and they're trained on hundreds of thousands of images. So they can deliver the accuracy. However, we must be a little bit mindful as to how we use them, especially if they are moved towards a decision-making perspective. For things like ECG interpretations, some of these systems can analyze waveform patterns allegedly better than a human at higher sampling rates, and they can detect some cardiac abnormalities with a greater degree of accuracy. So there's some obvious benefits here with some of these kinds of tools. When we move to predictive analytics and these kinds of AI models, these include lab values, vital signs, medication adherence, and even some social care determinants. The approach involves engineering from electronic health records, calculating risk scores, and updating predictions in real time as new data arrives. So from moving slightly a tangent from a secondary care, some of the hospital admission prediction models have got good accuracy scores, and they do incorporate factors such as recent visits and what I've said previously around medication history and changes and seasonal patterns. So we do see some obvious benefits there. Moving finally into digital therapeutics and monitoring, over the last couple of years, we've seen quite an exponential rise in digital therapeutics. These are around continuously optimizing the interventions based on patient response patterns, behavioral data from wearables, and clinical outcomes. These wearable integrations are taken from multiple integrations with other use things like application programming interfaces, little interfaces between the software so that the device can talk to other devices and consume this data. And the sorts of data that we're seeing more often now, blood pressure, glucose monitoring, activity patterns from accelerometers in mobile phones, all sorts of useful stuff. Now, with all of this as a possibility and a really exciting area, I'm just looking at how we can implement all of this stuff safely and come up with some very sort of general guidance for implementing this kind of AI. And we can expand on this in the panel and also through future guidance that we jointly publish with our colleagues at Redmore. So I've seen quite a few implementations from an AI perspective done really well, and I've seen some done pretty badly. So I have seen a broad selection of what good looks like and what bad looks like. However, I'm of a position where I don't pretend to know everything. I don't pretend to be an expert in any particular field. I'm always learning. I'm always looking for the latest advice, the latest research. And that gives me more of a humble position to constantly learn, constantly improve, and share that insight with others who maybe don't have the time or hasn't got a role like me that is a bit of a standards and a regulatory geek. So from a regulatory compliance perspective, you can see NHS England's letters reinforce the assumption that many of these topics are, or these products are medical devices. They urge the clinical safety standards compliance particularly from a health organisation's perspective, the DCB 0160. So, and these provide the best methods for assuring a product and also implementing it safely. Once a manufacturer moves into the medical devices territory and has to comply with that legislation, it's a very prescribed industry. There is a template for any kind of requirement-based document or legislative requirement. And so that provides consistency and consistency from those, including the regulator, notified bodies if it's a high-risk product, or the user of the systems, to consistently review content in a familiar format. And so that, I think, is one of the drivers for NHS England's letter, away from the obvious in terms of the power of these products. From a GDPR perspective, some of these systems are vastly complex, and implementing privacy by design principles around dynamic algorithms are mesmerizing. So there has to be a burden on the manufacturer for providing some form of a guidance as to how one would use these products safely, but also from a data governance perspective, how would one align with Information Commission Officer and data protection rules. And this kind of guidance should be generalised and proliferated across the NHS completely freely, so that everybody can absorb it, everybody can have simple checklists and comply with a little bit of ease that there's been a lot of review and a lot of experts poring over this kind of content. From a clinical safety officer perspective, something that isn't in the clinical safety standards, but something that I'd recommend as being original author of the standard, is that your clinical safety officers must have an awareness, just as you guys, if you're using these tools, must have an awareness in some of the basic AI terminologies, principles, and where the risks may lie. Because that will help doing a risk assessment on your implementation and use. And that's only where your focus should be. You shouldn't be helping any of the suppliers of these systems develop and design the products. You should be looking for help with implementing the products. So all of these technical requirements, having this evidence base and complying with these requirements provide, like I said before, really consistent way of meeting the requirements. You have an audit trail for some of these dynamic systems should anything go wrong. From a data protection and impact assessment perspective, you need to map exactly how personal data moves through each component of the AI system. This is in many of the different EU AI Act, GDPR based and standards based AI requirements. Looking at differential privacy techniques, privacy and training data sets. I won't go into this too deeply. It isn't a subject that I specialise in, but it's one of these obvious, more obvious from a compliance perspective requirements that if the system is more dynamic in nature, then the principles for complying with a particular area, such as data protection, should be more rigorous and dynamic itself. We need these systems to be able to trace where the data's come from and how it's been trained. Now, moving into something more practical and operational is around staff training and engagement. And this is where my bit perhaps goes a little bit, creeps a little bit over into Redmore's speciality. But from a regulatory perspective, there are some requirements around training and user engagement and how you understand to implement and use these tools. So you must have a basic understanding of these tools, the different terminologies and some examples. And I believe there's vast resources around the NHS out there and on YouTube that gives you bite-sized learning from 5-minute understandings. You need to, when you start using these systems with the provider of the system, you need to understand how some of these models may become a little bit less reliable over time. So that's drift, the technical term. And we need to implement some form of a monitoring tool to make sure that there is a statistical way of monitoring and capturing that maybe the product's not as accurate over time as it should be. We need to have some kind of an understanding of how the training data has been derived and understand why some of these AI systems make specific recommendations. That will give you some, and the term is around explainable AI. Why is that significant? We can talk about that on the panel. Any kind of continuous learning infrastructure should include a performance dashboard, or it could include a performance dashboard, some way of alerting whether or not the system is underperforming or overfitting or drifting away from its key performance indicators or its technical specification that it's been implemented. Now, in terms of patient consent and transparency, I've talked a little bit too much around data protection impact assessments. Consent management systems need to handle the permissions for different types of AI applications. We need from manufacturers to have the information around the right to explanation of the human readable explanations for historical decision. We need to have some form of a good technical way of withdrawing consent for your data to be used on these systems. So that's a little bit of a complex area and something that would probably take a little bit more to discuss, but lead us to say that the consent model with these applications is pretty complex and requires further guidance and further instruction. And I think that working with Redmore, we can probably come to a really good place with something that's simple, quick, checklists based, knowledge sources for further learning, and actually to work with maybe a few manufacturers to improve the way that they roll out their systems within the NHS. That could be a good thing, right? So the final thing for me, which I hope I'm going okay with time, is so I've worked in healthcare technology for quite a number of years, and I have said I have seen what good and bad looks like. In terms of cutting corners around regulation, if we have some of these products that aren't medical devices, they are unregulated, then you have a different challenge around being comfortable with whether these products will operate over time within the parameters that they specify, whether they may suffer from any kind of bias, whether the training data doesn't represent the full spectrum of your patient population, for example. And in a more regulated environment, these are requirements that are enforced or certainly good practice. Small changes to any input data that can cause some wildly incorrect predictions. So we must have some way of controlling or mitigating or having an awareness of how these may impact the systems. Another term that comes into it is gamification. We've had and worked with some of our clients where a patient has repeatedly gamed the bot to get in a less risky decision rather than an urgent care referral. And so some kind of operations or process that wraps around that, so that you guys are comforted that if somebody tells you the incorrect information or enters the incorrect information in the product, then you can't be held wholly culpable or liable for the outcomes of that application. Some of the legal and financial repercussions are well noted in the media. There are a number of organisations that have been penalised for data breaches, not just for AI, but standard practice, standard health software products. So a lot of these do erode the trust in the technology, and this is something I think that's a joint responsibility between those who use the products and those who manufacture the products, where we find a middle ground to celebrate and socialise good practice, good implementations, insights on how to more effectively measure these products are working well, and also good practice on how to implement these models without taking too much time away from the GP practice. Because not every GP practice will have that regulatory insight or the ability to draft that in. So we need something that's quick, meaningful, and pretty good. So that's my closing bit on the slides. Is the potential benefits of AI are vast, but they must be pursued responsibly. I have the luxury of working with a number of clients that are AI manufacturers that are all looking at best practice, the latest guidance, and what they can do more to safely protect their products. I won't work with a company that doesn't. We're looking at the regulations and the standards, in my view, are just boundaries in which we can play safely. Good governance isn't a barrier to innovation. It's a foundation that makes us a sustainable, innovative industry. So that's the end of, or the last of my presentation. So I'll hand back to more people.
Yeah, thank you very much, Stuart. Thank you. And I hope everybody found that really useful, because there was loads of information in there. Like Stuart said, we are offering a joint support package for practices or PCNs between Redmore Health and Ethos, where you'll get expert guidance, 2 days of training for a nominated clinical safety officer and one other team member, and hands-on support tailored to your needs, so you can save time, reduce risk and improve care with the reassurance of doing it safely. So if you want to find out more about that, more details will be on the D&T Network, but you can also contact us on our email there. And as we said before, the AI avatar video content, we run a service through the social media managed service. Through that, it's a personalized multilingual video content, and it supports better communication and continuity of care through a new AI avatar. You can use it for GP practices, pharmacists and private health clinics, but it creates a professional video without having to film a thing. So without further ado, we will move on to our live Q&A. Now, I'd like to introduce to you today, we're very lucky to be joined by Dr. Amar Ahmed and Dr. Aaron Notanay. I think, would you like to do a small introduction to yourself? Who'd like to go first?
Aaron, after you.
That's very kind, Emma. Hi, my name's Arun Otani. I'm a GP partner in Wembley in northwest London. I have a practice. I've been a partner now for 16 years. Our list size is about 15,000. But a couple of years ago, 2 years ago, I started working to build an automation company called GP Automate, which now automates work in general practice and is in about 200 practices across the country. We currently work with Stuart in Ethos as our clinical safety team that adhere to hopefully keeping patients and clinicians safe using our software. Thank you.
And I'm Dr. Amar Ahmed. I'm a GP partner here at Winslow Health Centre for the past 25 years. For 20 of those years, including now, I'm a GP trainer. And what brings us to this forum is that we've been early adopters in all kinds of tech since my time here. And more recently, we've been reviewing tech products on behalf of all our colleagues in general practice, including AI, scribes, training products, use of ambient AI in training our registrars, use of AI in augmenting ultrasound and echoes that we do here. And we've also just gone down the route of the first brand new EPR in 25 years in primary care, which is Medicus, and we were the first to switch from EMIS a few weeks ago. And in fact, I think Stuart's company did our governance for us. So yeah. And Stuart, am I right in thinking that you wrote the spec for the DCB stuff, DCB 0129 and 160?
Unfortunately, yes. I still have the target on my back. Feel free to print my face out and put it on a dartboard.
Okay, that's fine. So you know your onions when it comes to this, then.
I have gone through the pen. I've spent quite a number over probably about 15 years in the NHS. I worked with now Professor Maureen Baker. She was the president of the Royal College of GPs. So we co-authored the clinical safety standards as international standards at the beginning, but it's fair to say that there was a lot of politics at the time, and medical device companies abstained from adopting them. The irony was 5 years later, Maureen said, let's go ahead anyway and do an NHS standard. We'll sort the UK out and look after the NHS. So we went ahead. 5 years later, the international community asked us back to write the very same standards internationally. So we can see the benefit that patient safety in a digital context is bringing. There are different methods in different countries of ensuring that safety is considered. The UK does it well. I think it is time for a change, but I think the standards can, in my view, I think the standards are fit for purpose because they're suitably high level and less prescriptive, and they were written in a standard that guidance can be published regularly to handle new technologies such as this without interrupting the higher level standard itself. So yeah, it's been a long journey, and I absolutely love it now that clinical safety is now probably shoulder to shoulder with cybersecurity, and rightly so.
Fab. We've got the right team on then. That's good to know. I've got some questions in our Q&A. So we've got one that I don't know if we've already answered, but it says we've been reading about the need for DPIA as well as DCB 0160. Can you advise on what surgeries should have in place when using AI, please? Who would like to answer that one?
I can go first, only
Yep.
to suggest that if you get into contact with Redmore, we have some guidance that we can offload, and there is I think you've got a central area through Redmore where you can get access to blueprint toolkit or guideline documents. We are working with Redmore to make sure that our content has the regulatory side of things, just enough good practice, real common sense, plain English, but it folds into the way that Redmore help and support their clients in primary care, so that it's very consistent and it meets those needs. So I would say that guidance could be available as soon as next week, because I've already written it, and it's going through our QA process internally. So and it's a little bit more than a kind of a couple of minutes response on here. So I'd say go to Redmore, the contact details through this presentation, and you'll probably get some good guidance, and we can probably help you.
Fab, thank you. Emma, you've just put something, is that one of your YouTube videos in the chat?
I have, yes. So
Fabulous.
this is, we are jobbing GPs. We don't get paid for any of this. The reason we do all of our reviews is to make life easier for our colleagues. And that's one of the videos that we've done there, because it's a minefield. And rightly so, actually, because it's a really powerful tech. It can go wrong. We have to use it responsibly. So you have to make sure all the checks and balances are there. So that's why we made that video, to kind of guide people through it. With a little AI provided by Dave Trisker as well. But we're actually stuck now because since the letters, the cease notices, as we've called them, have come out in the past few weeks, practices are actually taking on a heck of a lot of risk if they don't go through all the correct governance. And actually, ultimately, correct me if I'm wrong, Stuart, but it's up to our ICBs now. I mean, if our ICB doesn't sign anything off, we're totally snookered.
It depends on the arrangement, the contractual arrangement for commissioning that they have with the ICB. Some solutions are region-wide procured by the ICB, and the requirements for the ICB are met centrally as a commissioning organisation. And what should happen is with a bit recognising the size of a GP practice, the responsibility, and also the number of people in the GP practice who can actually do something around implementing it safely. The clinical safety requirements should be significantly less than the central commissioning effort.
So let's say I've procured something myself, like Heidi or Tortoise or whatever, and it's got nothing to do with the ICB. The ICB still has to sign it off, or as long as I've done my due diligence, I'm okay to go.
So if you've procured it yourself, then you are acting pretty much like the ICB. So your clinical safety requirements will be a little bit more and more considerate from a 160 perspective. If you're implementing through a previously or already commissioned through the ICB product, then it'll be significantly less.
Okay,
Aaron?
thanks.
Yeah, Amar, great question and great answer, I think, from your discussion between you guys. I think from my perspective, I think it does depend on which ICB you're in, because I know in my ICB and for all the people that are attending, different ICBs have different rules and regulations. Birmingham, for one, is one that's, quite a very heavily regulated in terms of software that goes through. My own ICB, Northwest London, again, has to go through an assurance and approval process before implementing anything. So you kind of have to let them know. So it does really depend on your ICB. So definitely do check with your ICB IT department.
Fab, thank you. And I think this question would also be for you. So how do AI systems train without consultation data, which can't be 100% effectively anonymized, being released into the wider internet? So that's to do with sort of how these things work. Can you answer that one?
Good question. I'm actually not sure. So obviously our product automates lab reports, registrations and prescriptions, but we don't. I'm not as au fait with the AI scribe. Amar, it sounds like you'll probably be more adequately educated to be able to answer that.
So I mean, the AI scribes that we've reviewed, they've all got +1 now. So we're starting at that level. You need to make sure they've got at least +1 medical device status. But the firms that we've gone to, they've produced the document, which is the DCB 129, which is their own clinical safety checks and their own governance checks that they've done. And we've also asked them questions about how they kind of anonymize the data going out. It is really complicated, and there are some of my colleagues who actually don't accept some of the stuff that some of the AI companies have actually put in those documents. For instance, there are snippets of data that could potentially be sent out to the servers, the AI servers, and they actually don't sit in the EU. But the way that they're saying that they're getting around that is that it's totally anonymized. So, but does that conform in the true sense of the word to all the stuff that's in the GDPR regulations? And that's, I think, an ongoing debate. Stuart probably know more though.
Yeah, there's to generalize, it's not a subject I specialize in, but from my understanding, there is a level of encryption on this data, both internally within the manufacturer's product and their use of it, and also when it lands at a GP practice. And the flow of data has that level of encryption. I'd agree with the panel that there's not any immediate guidance around this. We can only surmise that some of the future publications from a NHS information governance and international standards perspective around data governance and data protection will provide some of the answers and some of the guidance.
Fab, thank you. And then just one last question. So the NHS England is now asking stating that a clinical safety officer must have 2 days of training for these AI products to be put in place. Do we know whether that is a clinical safety officer in each practice, or is that one per PCN? Will that suffice? Does anybody know the answer to that one?
I do. And well, I can't assume to know what NHS England's thinking. I don't think anybody can. I don't think NHS England can. Just add a bit of candid here. So the clinical safety standards themselves say you need a clinical safety officer. That clinical safety officer can be subcontracted, it can be part-time, and I would say that the effort is based on the risk. So if there's only a couple of systems, then you could utilize a clinical safety officer. There are many companies out there, and just use one. But what I would also suggest is interrogate those clinical safety officers to see just what subject matter expertise they have in this area of technology and how they would call themselves suitably qualified to work with these kinds of systems. And there's lots of tools out there, ChatGPT, Microsoft Copilot. You can ask it to create you some model interview questions for a clinical safety officer. Let's use the tools as a productivity tool for ourselves to look at some sensible guidelines and checklists to see whether or not you're getting somebody who knows what they're talking about or not. So yeah, and you can certainly, I think, have a clinical safety officer per primary care network. If you're all using the same tools, I would say there's a lot to be offered from an economy of scale in using one or a few CSOs that cover a particular patch. I certainly wouldn't go down the road of having one per practice. I think that's ridiculous. And I also would say that if you are looking for a CSO, whoever you choose to work with, make sure that they have within the contract a way of giving you the insight to work to do it for them yourself. Don't contract something that you can't get rid of. When I worked in the NHS, I used to hate consultants, and it's ironic that I've become one, but I could never get rid of them in the NHS. So make sure that your contracts are really clear that over time you would like to be able to do it for yourself and lessen the dependency on externals. And by doing that, you will keep your consultants on the toes.
Fab. Thank you very much, Stuart. And thank you very much to Dr. Amar Ahmed and Dr. Arun Natali. Hope I've got that right this time, for joining us today. We have got more questions in the Q&A, but unfortunately we've run out of time. All of this information will be on the D&T network, but I'm just going to pass over now to Sarah to close the session.
Yeah, so before we let you go, we'd be grateful if you could fill out as feedback form. You can see the QR code there. It's really useful for us to know what went well and what we can improve for next time. Also, if you do fill it in, you're going to a draw to win a £25 Amazon voucher. And just a quick final question for you all, if you can just quickly answer as second poll. If you don't already use AI in your practice or PCN, would you consider using it after today's session? Kirsten, if you wouldn't mind just quickly launching that for us.
Yeah, it's just in the process.
Thank you. I'm just gonna move on because I know we're past. So as we mentioned earlier, recording and resources that we've shared with you today will be available in our D&T network, and it's under the AI category, as you can see on the screen. And then the D&T Hub, it's your ultimate tool for driving progress in primary care. If you don't know about it, get in touch. It starts with a quick 20-minute assessment to assess your personalised digital and transformation maturity dashboard, a visual snapshot of your strengths and opportunities for growth. And then after that, you can unlock its full potential, which is a platform designed to help you assess, plan and implement transformational changes to do with communication, streamlining workflows, optimizing patient journeys, and lots more. So yeah, thank you for joining us today. I hope you found the session useful. And if there's any questions that we haven't been able to cover, we'll pop the answers into the D&T network topic for you to catch up on. Do we have the results of that quick poll at all?
Yeah, so 61% would consider implementing
Fabulous.
AI after today's session. So I think that's a good. And they've got 29% maybe, and 4 people or 9% have said no. So there's still a little bit of nervousness there, I think I would say. But yeah.
So that brings us to the end. Brilliant. Thank you for joining, everyone.
Thank you. We'll let you go.
Thank you.
And thank you very much for joining us today.